Today we're going to discuss a condition which is known as proptosis. So how do you basically define this condition which is known as proptosis? It is the abnormal protrusion of the eyeball which is considered as to be proptotic in an individual. Patients usually don't present complaining of this proptosis. It is a sign that is most importantly observed by the clinician himself or herself. So it is this condition which is observed by the clinician and not by the patient himself or herself. There are these certain characteristics of proptosis that we'd be considering over here in this lecture. Obviously, this condition has its own complications. There are a lot of situations that the patient is being exposed to when he has or she has a proptotic eye. That is basically the eyeball is protruding in a forward direction. So there would be the risks of exposures to the environment. Sometimes the patient can be exposed to developing a syndrome which is the KCS, that is the dry eye syndrome, keratoconjunctivitis. That is due to the functionality in which the eyeball is basically protruded out quite abnormally due to multiple reasons, of course. The reasons that are hindering this condition, there are multiple risk factors towards the development of a proptotic eye in the individual. Sometimes the term proptosis is confused with a term which is known as exophthalmos. Exophthalmos is again the forward protrusion of the eyeball, and both of these terminologies are quite intermingled. But unconventionally, exophthalmos is a condition, or exophthalmos is a terminology that is mostly given to a condition in which there is a forward protrusion of the eyeball and which is usually connected towards thyrotoxicosis, that is the increased levels of thyroid hormones in the body of an individual. So usually the term exophthalmos is used for these individuals, and proptosis is used for the multiple other factors which also lead towards the forward protrusion of the eyeball in the individual. Now, the multiple risk factors towards the development of a proptotic eye can be a vast variety of there is a list of basically causative factors towards the development of this forward protrusion. That can range from trauma, as well as it can be some of the infectious material that can collect at the back of the eye, as well as the cellular infiltrates due to the development of the infectious state. There can be the multiple autoimmune disorders that can sometimes present with the cellular mass that is present at the back of the eye and eventually resulting in the forward protrusion of the eyeball in the individual. The optic nerve itself can sometimes be one of the causative factors towards the development of proptosis in the individual. For getting to know about this condition, which is known as proptosis, one should remember the applied anatomy of the orbital cavity. Orbital cavity can be considered as a pyramidal shaped cavity, which is having its base in the front and its apex at the back of the eye. So it's basically a cone-shaped cavity that is present. We have two of these cavities. So clinically, this can be a bilateral condition or either it can be a unilateral condition. Usually when we are referring to exophthalmos, it's basically a bilateral condition that is arising in the individual. On the other hand, unilateral conditions would be usually the tumorous conditions, for example, the cavernous sinus, hemangiomas. It can be the tumorous conditions, as well as it can be any of the infectious states that are arising unilaterally in one of the eye. So over here, just to give you an example and just to give you a better understanding of this condition, which is known as proptosis, we're just considering this kind of a condition in which there is this eyeball that is obviously situated in the orbital cavity. And then at the back of the eyeball, we have this optic nerve that is entering almost centrally and posteriorly and it is basically located at the posterior end of the eye globe. So it's basically if there is some sort of an optic nerve compression, as you can note down here. This optic nerve has basically all of the three protective coverings, including the dura mater. It has the pia mater, and then we have the arachnoid mater as the protective covering of the optic nerve. We have the arachnoid that is situated over here, and whenever there is a situation of the optic nerve compression, there would be the accumulation of the mass at the back, that is at the posterior globe of the eye, which would have its compression effects on the globe of the eye. And finally, there would be a forward protrusion of the eyeball. Even when we look at an individual laterally, that is basically from the lateral view of the individual, the cornea and the eyeball is slightly protruded, and that is a normal phenomena in the individual. When we examine the patients, it is a normal phenomena. But in patients of proptosis or in patients who are suffering from exophthalmos, when we'll be looking at the patient from the lateral view, there would be an abnormal protrusion of the eyeball that is almost a difference of 5 to 10 millimeters. So only then we'd be considering it to be a condition which is termed as proptosis in these individuals, or either exophthalmos. Both of these terminologies would then be used. There are multiple clinical methods by which we can observe the patient. We can have a lateral view of the patient, as well as we can observe the patient superiorly. So the clinician is basically standing at the back of the patient, and he or she is overviewing the patient from the superior aspect, and sometimes this condition, proptosis or exophthalmos, is severe enough that it is quite evident when we are looking at the patient from a superior view. So this is basically the different clinical methods by which we're going to observe the proptosis or exophthalmos in the patient, and then we can measure the abnormality as well by using a scale method. We can measure the amount of proptosis or the level of exophthalmos in these patients. So recalling the applied anatomy, we'd already observed that it's basically a pyramidal shaped cavity, and it's having the eye globe as the major constituent. There are obviously the other components of this orbital cavity. We'd be considering the bony structure of the orbital cavity first of all, which is basically having a roof. And then we have the lateral wall, we have the medial wall, we have the base of the orbital cavity, and finally we have the apex of the orbital cavity, that is the apex of the pyramid that we're talking about. All of this you have to just consider in your mind that these are the bony structures that are surrounding this eye globe that we're talking about. Eye globe is the component, the orbital portion is the component of this orbital cavity. Eye globe is contained by the orbital cavity. Along with this eye globe, we have the muscles that are attached to this eye globe, as well as we have the nerve components. Most importantly, we have the third, fourth, and sixth cranial nerve. That is the major constituent of the orbital cavity. And then we have the ophthalmic and the maxillary division of the trigeminal nerve. That is basically the fifth cranial nerve, and that is also contained by the orbital cavity. So any infectious states that can arise in the optic nerve, as well as the other nerves, the fourth, the sixth, and the fifth cranial nerve has its two subdivisions. All of these, if they have any inflammatory conditions, if they have any compressions, and they are inflamed, they can just push up the orbital content slightly forward and giving way to proptosis or exophthalmos in these patients. As well as the muscles that are attached to the eye globe, including the superior rectus, we have the medial rectus, the lateral rectus, the inferior rectus, superior oblique, and the inferior oblique muscles. These are the muscular attachments which are basically giving way to the eye movements in all of the cardinal directions. Any muscular attachment, if it is inflamed or if there is any trauma that is related to these muscular attachments, can again cause a swelling of the soft tissues, and again there would be a forward protrusion of the eyeball. So knowing the constituents involving the nerves, we have the muscular components, we have the lymphatics that are situated over here. And finally, you will recall that we have the lacrimal gland that is situated slightly lateral to the eyeball. We have two basic lobes to this lacrimal gland, including the orbital plot, and we have the palpebral portion of this lacrimal gland. So any tumorous conditions of the lacrimal gland, the inflammations of the lacrimal gland, that is the dacroadenitis that we've already discussed in that's a separate discussion, and we've already gone through that. All of these infectious states of the lacrimal gland, the tumorous states, the neoplasms, even the metastatic cancerous conditions can sometimes result in these proptotic conditions. Usually the tumors, the trauma, that would be resulting in hemangiomas, or that would be resulting in the hemorrhagic conditions at the back of the eye and the forward protrusion of the eyeball, would be basically considered to be of a unilateral presentation rather than a bilateral condition. Sometimes the condition arises unilaterally in one of the eye, and then it can encompasses or it involves the other eye as well. So this can be the state in a lot of patients. Then we have exophthalmos, that is particularly related to thyrotoxicosis, that is the increased hormonal levels of the thyroid hormone in the blood and resulting in the soft tissue swelling at the back of the eye and the final forward protrusion of the eyeball. When we are considering the orbital cavity, the lateral wall is basically made up of the frontal bone as well as the zygomatic bone. The floor of the orbital cavity is considered to be the orbital arch of the zygomatic bone. Then we have the medial wall, which is basically composed of the ethmoidal bone, the palatine bone, we have the lacrimal bone, as well as a portion of the frontal bone that is descending and forming the medial wall of the orbital cavity. At the apex of the orbital cavity, we have two fissures, mainly the superior orbital fissure, and then we have the inferior orbital fissure. Structures that are passing on primarily the nerves that are passing on the superior orbital fissure and the inferior orbital fissure, as well as the lymphatics and the arterial supply to the eyeball. All of these would be passing these fissures that are present at the back of the eye. So any of these structures, if they get inflamed or they have the tumorous conditions or the neoplasms, again, they'll give a push to the eyeball in the forward direction. And finally, there would be that proptotic or the condition of exophthalmos that is noted down in these individuals. The superior orbital fissure and the inferior orbital fissure is basically communicating the orbital cavity to the posterior and the anterior cranial fossas. And eventually, basically, all of the cranial fossas, including the anterior, the middle, and the posterior cranial fossas. So any infectious states can even travel from these cranial fossas towards the orbital cavity. For example, the cavernous sinus, which is basically located in the anterior cranial fossa, and if there is any thrombotic condition in the anterior cranial fossa, it can eventually present as the proptotic conditions in the eye. So basically, getting to know and discussing all of these conditions and the applied anatomical features of the orbital cavity is the mainstay when we are discussing this condition of proptosis in these individuals. As you can, it's just one of the conditions that we have explained diagrammatically over here, but we have to consider all of the components and all of the constituents of the orbital cavity whenever we are considering that there is a push from the back of the orbital cavity. So the structures have to be considered, and you should have a well-versed knowledge of the structures that are contained by this orbital cavity. So, considering the classification of proptosis, one should just have a view that usually this classification is based upon the clinical presentation of the proptotic conditions. As we've already explained, there is a unilateral kind of proptosis that is seen in these patients, in which basically what can be the causative factors towards the development of unilateral conditions. It can be a trauma that is just related to one of the eyes. For example, it can be a surgical trauma, or it can be even the direct blows towards the orbital cavity, which result in the hemorrhages at the back of the eye. As well as it can be a lot of infectious states involving the soft tissue masses that are contained by the orbital cavity, including the cavernous hemangiomas that can be present. So these congenital conditions are sometimes retained by just one of the eye, so it presents in a unilateral condition. For instance, it can be the Tennant's capsule that is sometimes inflamed only unilaterally in these individuals. Then there are some sort of congenital abnormalities, for example, the abnormalities of the skull that can present or make the individual more prone to the development of this unilateral proptotic conditions. On the other hand, we have the bilateral proptosis. So usually when we are considering a bilateral proptosis, it's a condition that is arising systemically in the individual. The individual is suffering on a whole by this particular kind of a condition. And it can be, for example, the raised levels of the thyroid hormones that are resulting in the exophthalmos in the patient. The patient over here who are presenting to you with the bilateral kind of proptosis will usually come up with the corneal ulcerations. On examination, you would just sometimes the inspection, just by giving a particular inspecting phase, you would observe that the patient has the forward protrusion of the eyeball. Sometimes it is a congenital condition and it is not accompanied by any of the pathological processes. So you basically ask the patient if he has the corneal ulcerations, or if he has or she has noted down this forward protrusion in his eyeball or not, and then you can just further investigate the patient. So first of all, the first clinical step towards the examination of these patients with unilateral or either the bilateral proptosis, you would consider the inspection, the complete inspection of the patient, and then finally the palpation that is coupled up along with this bilateral causes or the unilateral causative factors of the proptosis in the patient. The palpation would reveal whether the patient had some sort of a mass, and usually a lateral approach towards the palpation is the most accurate approach over here. Acute proptosis, so the history taking is again very important over here when we are considering these patients. You would ask the patient since when he or she has some sort of ophthalmic problems. Maybe the patient would not come up to you with exactly the word proptosis, but he or she would give you the history of a dry eye, the history of the foreign body sensations, or unable to basically close down his lids due to if there is an excessive kind of proptosis that he has or she has been suffering from. So the duration of the conditions has to be noted down, and you just jot down the time duration since the patient has been suffering from some sort of problems. There would be this intermittent kind of proptosis that is sometimes dealt in with. Now, this intermittent word is basically given to the pulsatile kind of proptosis that is seen sometimes in patients with cavernous sinus thrombosis, because this thrombotic effect or the vascular origin of the disease would be quite evident in these patients whenever they have a pulsatile or intermittent kind of proptosis rather than a retained proptosis in the other patients suffering from acute or pulsating proptosis. Pulsating proptosis is usually the aneurysms particularly. So aneurysmal conditions are usually the congenital conditions that arise in the newborns or in the infants. So usually they're going to give off the pulsatile kind of origins, and the clinical presentation would be pulsatile rather than intermittent, in which there is a duration of exophthalmos or proptosis, and then there is a proptosis-free period for a particular time period, and then that is followed by again a time period of a proptotic condition. So you have to basically differentiate the word pulsatile from intermittent in these patients. The clinical presentation is going to be thoroughly viewed over here. Having done with the clinical evaluation of the patient in whom you are suspecting proptosis or exophthalmos, and you have basically finally viewed and inspected the patient in details, and then given the palpation effects and jotted down the findings of the palpation, you can also perform percussion on these patients as well as auscultation. Auscultation is done obviously with the help of the stethoscope. So if it is a mass of vascular origin, you can finally auscultate the mass through the lateral approach. So that would be one of the steps of the examination over here in patients of exophthalmos or in patients of proptosis. On one hand, we have the unilateral kind of proptosis that we have discussed. So there are a lot of etiological factors, risk factors, and a lot of systemic conditions that can eventually present to you in a unilateral kind of protrusion of the eyeball involving just one of the eyeball. It can be the congenital conditions. So if it's just a congenital condition, the infant has been born through that condition, it would involve a dermoid cyst. It can involve the congenital cystic eyeball. Then we have the orbital teratomas. And on the other hand, we have the traumatic lesions. Considering the congenital conditions, you would just have a look that it's basically usually the tumorous conditions that are pushing the eyeball in the forward direction. Usually the dermoid cyst or the cystic eyeball is present posteriorly at the globe of the eye and giving a forward push towards the contents of the orbital cavity. On the other hand, we have traumatic lesions. Trauma also can be just involving one of the eyeballs. Sometimes if it is a blowout fracture towards the orbital cavity or any of the trauma which is just involving one of the eyeball, it will present in a unilateral kind of proptosis. For example, we have the orbital hemorrhages. We have retained infraorbital foreign bodies. So if there is a complete through and through invasion of the foreign body and it is located inside the orbital cavity, and finally there would be the cellular infiltrates and the inflammatory reaction towards the foreign body and pushing the orbital contents eventually. Traumatic aneurysms, obviously, sometimes there are a lot of congenital aneurysms, and on the other hand, we have the traumatic sorts of aneurysms as well. The emphysema of the orbit is also quite importantly known over here. We have another category which is basically the inflammatory regions, and they're also one of the important causative factors. We can further regroup or subclassify this inflammatory causes into acute causes, and then we have the chronic causes. The acute causes would be the orbital cellulitis, the infection or the inflammation that is relating to all of the components or all of the constituents of the orbital cavity, including the muscles, including the soft tissue mass, the cellular mass that is retained by it, the nerves that can be inflamed and resulting in a complete cellulitis kind of infections. We can have abscesses. We can have thrombophlebitis over here, panophthalmitis involving the globe as well, the infections of the globe. We have endophthalmitis as one of the variant, and then we have panophthalmitis, in which basically the infections travels from the conjunctiva cornea, from the anterior chamber towards the vitreous chamber, involving the whole of the eye globe. Then finally, we have cavernous sinus thrombosis. The chronic variety of this inflammatory conditions would include the pseudotumors. We have tuberculomas. We have the gamma formations, the sarcoidosis. It's another variant for the chronicity of the infections. So the acute infections would be on one hand. It can be any of the foreign bodies that are retained by the eye globe, or any of the abscesses and thrombal phlebitis. That would be an instant flare-up in the infectious states. And on the other hand, if it is a time duration of 2 to 3 weeks, we'd be considering it to be of a chronic type. Then we have the vascular regions. The vascular lesions would consist of the angioneurotic edemas, the orbital varix, and then we have aneurysms to be the dilatation of the vascular components can result in the aneurysms, and the final aneurysms are sometimes accompanied with cellular infiltrates and the inflammatory kind of reactions in the body. The cysts of the orbits can be one of the causative factors towards the unilateral kind of condition. These cysts can be hematic cysts, hydated cysts, implantation cysts, parasitic cysts, which are also known as or termed as the hydated kind of a variety. The tumors of the orbit would be consisting of the primary, and obviously we can have the secondary or the metastatic lesions of the orbit that can sometimes present like this. So they can be the secondary origins of the tumorous conditions. There can be the metastatic origins. Secondary and metastatic is sometimes very distinguishable because the secondary origins of the tumors would be from the neighboring structures. The tumors of the neighboring structures, including the tumors of the nasal cavity, the polypoid tumors, the tumors that are present in the fossas and that are retaining to and then metastasizing to the orbital cavity. And on the other hand, we can have the distant metastatic tumors, for example, from the other origins, for example, the tumors of the kidneys and the adrenal glands sometimes metastasize towards the orbital cavity as well. So these are the main causative factors towards the development of unilateral proptosis, which also includes the mucoceles of the paranasal sinuses. So even the neighboring structures are considered over here when we are considering the unilateral kind of proptosis in the patients. It would also include the nasal cavity. It would include the anterior cranial fossas. Infections, tumors, traumas can sometimes travel from these nasal cavities, including the sinuses, including the bones, the fractures of the bones, the nasal cavities, and they can enter into the orbital cavity and finally give off the appearance of a forward protrusion of the eyeball in the patients. And again, you have to remember it would be the unilateral kind of conditions that we're talking about over here. Comparing the bilateral variant of proptosis over here, we just consider over here that sometimes we have this condition of bilateral proptosis that is involving both of the eyes. That means that there is some sort of a systemic origin towards the development of this bilateral proptosis rather than something that is just localized. For example, trauma, infections that are localized just to one of the eye. In bilateral proptosis, it would be a systemic condition. For instance, it can be the raised levels of thyroid hormones, some sort of autoimmune disorders, some sort of infectious states that are systemically affecting the eyeballs and resulting in the soft tissue swelling at the back of the eyeball. The etiological factors over here would be the developmental anomalies of the skull that are one of the variants of the bilateral proptosis over here. Craniofacial dystosis is one of the variant of the dystrophies or the anomalies of the skull. So sometimes there is a thinning of the orbital cavity and the contents are basically pushed outward in these patients or in these infants. Then we have osteopathies. Osteitis deformans is one of the osteopathies that can be the relating factor towards the development of bilateral proptosis. Then the systemic conditions involving the osteoporosis, for example, rickets and acromegaly. So these will be the malnutritions that are resulting in the final proptotic conditions. Sometimes the rickettsial patients, the infants or the babies who are suffering from this condition of rickets, they present to you with exophthalmos or proptosis as well. A lot of inflammatory conditions also arise over here, and they are consisting of the Mikulicz syndrome, and then we have the late stages of the cavernous sinus thrombosis. So inflammations, as I've already focused upon this fact, that inflammations can travel from the neighboring cavities. The neighboring cavities would be the cranial fossas, would be the nasal cavities, would be the sinuses. So considering all of these inflammations and infections, we have the late stages of thrombosis in all of these, particularly the cavernous sinus thrombosis over here. Then we have the endocrinal exophthalmos, and we have the thyrotoxic or the thyrotropic variant over here. Finally, we have the tumorous conditions which can arise and they can even be presenting bilaterally in both of the orbital cavities. Symmetrical tumors, lymphomas and lymphosarcomas sometimes present to you with this sort of bilateral proptosis. Secondaries from neuroblastomas are quite notorious. And then we have nephroblastomas relating or pertaining to the kidney tumors. Ewing's sarcoma is one of the variant, and it is sometimes presenting as bilateral proptosis in these patients. And then we have the leukemic infiltrations. So systemic condition, leukemic infiltration, thyrotoxic, thyrotropias, all of these usually present in a bilateral condition of proptosis. We have histiocytosis as one of the systemic conditions which can relate to a bilateral condition. We have systemic amyloidosis over here, which is one of the notorious conditions. We have xanthomatosis as one of the major causative factors of the bilateral proptosis in the patients. We have Wegener's granulomatosis. So the investigations of these patients, the lab investigations, will be very prominently considered over here and relied upon, because just ruling out any of these conditions, any of these systemic conditions, would be the mainstay when we have patients of proptosis. Thyroid levels have to be checked, CT scans and MRIs are done, abdominal KUBs are done and referred to whenever we want to rule out the Ewing sarcomas or any sorts of Wegener's granulomatosis in these patients. A thorough investigation, a thorough systemic evaluation of these patients. Obviously, the baselines would be done, revealing any infectious states or any states of autoimmune disorders that the patient of proptosis are suffering from. Clinically, we can divide proptosis into an acute variant, and then we have an intermittent variant and a pulsatile variant. The acute kind of conditions would have their etiologies as described over here. We have the orbital emphysemas that the patients can be suffering from. Then we have the fractures of the medial orbital wall. So usually the traumas are the major states of the acute presentations, because the hemorrhages would usually push up the orbital contents in the forward direction. For instance, it is usually the medial orbital wall, but it can be the lateral wall or the roof or the apex or even the floor of the orbital cavity that is involved in the blowout fractures. Then we have the orbital hemorrhages that are to be considered and that are sometimes quite related to the traumatic conditions that the patient is suffering from. Finally, we have the rupture of the ethmoidal mucocele that is considered over here. So it's usually the acute stages, and the proptosis would develop in almost a period of less than 24 hours in these patients after the major onset of all of these conditions. Either if it is the emphysema or a traumatic condition that is coupled up with the fracture of any of the walls of the orbit, it would be almost less than a period of 24 hours and the patient can be seen with a proptotic eyeball. Then the etiological factors that are particularly pertaining to the intermittent proptosis. We've already considered that it's usually the cavernous sinus thrombosis, but we can have the orbital varix, we can have the periodic orbital edema that is observed in these patients. Sometimes there is a free period, that is a period free of proptosis and a period free of orbital edema that is seen and that is noted down. And we have to note down the free period, the time duration of the free period over here. The recurrent orbital hemorrhages, because that would basically prevail towards the etiological factors. And finally, the highly vascular tumors are also investigated over here. On the other hand, we have the pulsatile proptosis. So there are multiple risk factors towards the development of pulsatile proptosis in these patients. Usually, the etiological factors or the causative factors would be vascular in origin, because pulsation is a feature that is quite closely related to the arteriolar origin of these causative factors. Over here, we can have a pulsating vascular lesion that is particularly related to the keratico venous fistulas. That is basically a form of the AV fistulas, that is the arteriovenous fistulas. One of the names is given over here for the fistulas that are formed in the anterior cranial fossas. Then we can have the saccular aneurysms of ophthalmic arteries over here. And finally, we have the transmitted cerebral pulsations that are seen over here, including the congenital meningoceles. We have the meningoencephaloceles over here, and the neurofibromatosis as one of the variant. And finally, lastly, we have the traumatic or the operative hiatuses that are noted down over here. So you can see that the major grouping techniques are the pulsating vascular lesions, and on the other hand, we have the transmitted pulsations from the cerebral origin. It can be the vessels of the orbital cavity itself, or either it can be the pulsations that are carried forward from the cranial fossas. So it can be one of the factors over here. Any of the vessels can be involved. As we've already seen, there is a lot of communication between the cranial fossas, between the nasal cavities and the orbital cavities. So either if it is a tumorous condition or if it's an infiltrating infectious condition, all of these would be communicated in between these fossas. The clinical evaluation is the mainstay when we get a patient of proptosis. The history taking is very important. You'd ask the patient about the age of onset. You would ask the patient about the nature of onset, whether it was quite an abrupt kind of onset or was it not quite noticeable by the patient or by the people who were surrounding him. The time duration would be obviously whether it is an acute condition arising for less than 24 hours or if it is a condition that is prevailing for more than 2 to 3 weeks. And then obviously the progression of the disease, if it is a slowly progressing disease or if it is an acutely or an aggressive kind of a condition, then the chronology would be noted down, and then finally we'd note down the associated symptoms along with this proptosis. Obviously, if it is a patient of thyrotoxicosis, he or she would be giving you a history of sweating, weight loss, and all of these are basically the features of thyrotoxicosis as well as tremorous conditions noted down in hyperthyroid patients. The clinical evaluation would consist of inspection. Inspection is basically done from a lateral view as well as from a superior view in which the doctor is just standing behind the patient and he's overviewing the patient from the back. Then we have palpation. On the other hand, you would basically, if it is a pulsatile kind of proptosis, you would examine if it is having those pulses or not. And that would basically reveal or jot down or narrow down the differential diagnosis if it is found to be a pulsatile kind of proptosis. And finally, again, if the proptosis is of vascular origin, you can perform auscultation in these patients, usually from a lateral approach. Transdermal illumination is done in these patients And then we also perform visual acuity if it is hindered, if it is of an optic nerve, if optic nerve is also involved in the pathologies, there would be a decrease in the visual acuity that is noted down in these individuals. Pupillary reactions are also noted down. We perform fundoscopy for any abnormalities that are found at the retina of the individual. Ocular motility, you ask the patient to look in the all of the 6 cardinal directions and note down any abnormalities in the eye movements, and that would reveal if any of the muscles or the muscle attachments are affected in these patients or not. And then finally, the exophthalmometry, that is the evaluation of the level of the exophthalmos in these patients, is also noted down by the use of a scale. The lab investigations would be, the target would be to reveal if the patient is suffering from some sort of systemic infections or not. Relating to the thyroid function tests, the hematological tests would include the TLCs, the DLC, ESR, and VDRL that would evaluate basically any of the infectious and inflammatory conditions in the eyes. Obviously, the Cassani's test is performed, and then we perform the stool examination to rule out any of the parasitic infections, and urine analysis is also done for any of the systemic conditions, again, in cases of Ewing sarcomas or Wegener's granulomatosis, you'd observe any differences in the urine analysis as well. The imaging techniques include the plain X-rays, the computed tomography scanning, that is the CT scans are done, ultrasonography to rule out any systemic metastatic tumors in the abdominal, in the thoracic cavity, or sometimes in the cranial fossas. And MRIs are also performed, again, to rule out any sorts of tumorous conditions in any of the body cavities. The invasive procedures would include the orbital venographies, the carotid angiographies, and then finally we have the radioisotope arteriography. All of these would be to target any sorts of aneurysms in the patient, to rule out any sorts of cavernous sinus thrombotic effects in the patients, and all of these, any thrombotic effects as well as any compression effects, can be noted down when you perform these invasive kind of procedures, targeting the arteries and the venous sinuses particularly. Histopathological studies would include the fine needle aspirations done for the tumorous conditions, incisional biopsies, specifically again for the tumor markers, and the excisional biopsies done in cases of any sorts of masses found at the posterior lobe. The treatment would be, obviously, considering the etiological causes. There would be a general symptomatic treatment, giving lubricants to the patient, tapping the eyelids, and cold compresses. And then we have the systemic steroids that are given to the patient, just to hamper down or hinder down any of the cellular infiltrates at the back of the eye. We'd be giving the oral prednisolone, 60 to 80 milligrams per day, that is tapered over 2 to 8 weeks. Intravenous methylprednisolone, almost 0.5 grams per 200 ml isotonic saline infusion for 30 minutes. Radiotherapy is given alone or with steroids, and sometimes we also give off the combined therapy along with the systemic steroids, along with the general therapy, and that is the usual treatment modalities that are given along with the radiations. Azathioprins and steroids are also given. Finally, if the patient is not relieved of this condition, we perform the surgical procedures to give a final view. We have another terminology which is known as Enophthalmos, which is basically the inward directed ways of the orbital cavity, in which basically rather than the protrusion, there is the backward movement of the eyeball. This is known as an enophthalmic kind of a condition that arises in these patients, and the causative factors towards the development of enophthalmos can be the cicatricial tissue. It can again be one of the traumatic conditions that can arise in the eyeball, as well as it can be the congenital conditions that arise in the eyeball. So there would be a variation from the normal. The diameters have to be noted down, and then you basically jot down the different causative factors towards the development of enophthalmos in the patient. So over here in this lecture, we just summarized the different causative factors towards a condition which is known as proptosis. That is the final outward protrusion of the eyeball. We dealt in with the symptomatology, and one should be well versed with the differential diagnosis in a patient who presents to you with proptosis. So that is the end of this section. Thank you for watching sqadia.com.